So difficult. In some ways it's kind of like using which aromatase inhibitor do you want to use today, because the non-steroidal aromatase inhibitors appear to be relatively equivalent in the endpoints we can look at. I think the tests all seem to have prognostic capability in the populations that have been studied. The predictive capability is another question. We tend to use the tests that we feel have the most robust predictive capability when we're trying to answer that question. We're going to give you hormone therapy. I don't know how much benefit chemo will provide, and maybe this test will help us come to a conclusion. If I already know I'm going to give chemo, or I already know I'm not going to give chemo, then sending the test is not going to be helpful. And I have seen situations where you absolutely know that patient cannot tolerate chemotherapy. They have a low-risk tumor by the clinicopathologic criteria, and they send a test, and then it makes everybody feel, oh, it's intermediate, what should they do? But the patient already can't tolerate chemotherapy because of morbid conditions. So in that situation, it's not useful. I really think that you have to, as a clinician, feel comfortable with the predictive capability of a test. And then I think that test is useful for you to answer the question. For a prognosis, it's interesting in oncology, in the early stage setting, if you don't know how to impact the prognosis, a prognostic test may not be quite as useful. And the subtype analyses that are provided by the blueprint test, where you look to see whether somebody has luminal A or B or basal-like, so far we don't know how to incorporate those into clinical practice. So I would discourage sending a bunch of tests that are very costly and don't aid you in making a clinical or treatment decision.